Great. Thank you all for coming today. This is the webinar series on behalf of the DaRe2THINK team, which, as you'll find out a bit later, we're running a national primary care clinical trial service to help primary care and patients around the country involved in NHS research. It's a great pleasure to welcome today Jeremy Dwight to our group. So I've known Jeremy for quite a number of years. Jeremy was a retired cardiologist in Oxford, and after his diagnosis of AF, he's really been helping to shape the patient side of the management of atrial fibrillation, and last year took part in the 2024 European Society of Cardiology guidelines on atrial fibrillation, where I got reacquainted with Jeremy, and he's led some great stuff around how to make the care of patients optimal for clinical practice. So thank you so much, Jeremy, for coming to give us the talk. As you can see, there's still some people filtering in, but I suggest we just kind of make a start, and we're really glad to hear from your thoughts on the patient side of that journey.
Thank you very much indeed, Deepak. It's a privilege to be asked to speak to this audience. I'm going to share my slides and just get started here. So hopefully you will be able to see the presentation now. So I'm going to talk about the ESC patient guidelines for atrial fibrillation, and in general give you a patient perspective on the management of atrial fibrillation. I have atrial fibrillation. Both my parents had atrial fibrillation, so I have a certain vested interest in this particular condition. When we think about things from the patient's perspective, often discussing things with other AF patients, there are a number of issues that come up. It's a condition in which it can be managed both in primary and secondary care, or a combination of the two, but sometimes patients have a difficulty in accessing the appropriate healthcare right at the beginning. And this is about how establishing the diagnosis and who to visit first. We have a condition which affects an elderly population, often with multiple different comorbidities. And as I'm sure you will have seen in your own practice, there is a degree of fragmentation of care that occurs, which can be quite challenging for the patients. So in other words, they may be under a respiratory physician, a cardiologist, under their general practitioner, and a variety of different specialists. And that has particular challenges in terms of continuity of care, and obviously the importance of communication. And I think we increasingly realize that the major continuity here, because of the difficulty and the number of agencies involved, is in fact the patient. And the patient's understanding of their condition is very important in facilitating that process. Although for medically qualified people, AF may seem a relatively simple condition, it's actually quite complex in terms of its management and the numbers of drugs that the patient has to be on, and this can be confusing. And there are a number of treatment options that the patient needs to be guided through. One of the other challenges for the patient is that they often, when they get to their primary source of treatment, they get excellent treatment, and they're very complimentary about that. But then they're left out in the wilderness to a degree once they're discharged from secondary care. We know that there is this drive to discharge patients from secondary care. And the idea is that this is picked up in primary care, but everybody realizes what a major challenge that can be. And some questions, for example, when should the patient represent, or when should they seek advice, becomes increasingly important. From the point of view of the healthcare professionals, obviously we have a condition which is increasing in incidence and also is more readily detected. And we've got more individuals who are picking up atrial fibrillation with devices, etc., watches, etc. And then this elderly group of patients, we often have numbers of things wrong with us. So, for example, I have hypertension as well as atrial fibrillation, a very common combination. But we've got a lot of overlapping conditions where it's not entirely clear sometimes for the patient as to what's causing their symptoms. So is it their chronic obstructive airways disease? Is it their ischemic heart disease? Is it their atrial fibrillation? And then we have all of these management protocols, and I have a great deal of sympathy for those in primary care, because here we are dealing with just one. And for every one cardiology protocol or guideline, there's going to be a dozen others in a whole different series of specialties. So the important thing is to keep it simple and to make sure that it is achievable. And I think the patient aspect of things in terms of patient education fulfills both of those criteria. The consequence of this is we tend to see that there is a relatively poor adherence to guideline recommendations, or certainly not as good as we would like to see. And the question is, can we improve that, and improve that in particular by engaging patients in the management of their condition? Now, when I drew up this rather complicated diagram, it was designed to show all of the different subspecialties and components of the healthcare system that might be involved. Importantly, we put the patient in the center. But the fact is that only a very small proportion of these will affect any one individual patient, but it makes it more difficult to think of a very standard patient pathway. And so every patient's pathway is different. And we have to think of ways of improving the patient's passage through these different aspects of the NHS care. So that's the pathway that some patients will experience, not something straightforward, but they will bounce between accident emergency, for example, if they have an emergency admission with AF, or they may come in under a stroke physician, or they may come in directly to increasingly to primary care or secondary care, often by self-referral, if what the government strategy is going to be takes place. And so it's very important that patients actually understand what is happening. And this is the major emphasis of the patient guidelines. We can think of a whole series of questions that could be asked. I'm not going to go through each of these in turn, but what we have here are questions regarding what is the cause of the atrial fibrillation, what is the cause of the symptoms. But there are a number of other questions which will involve joint decision-making in terms of how the patient is followed up, who they should seek and help from, and who should they contact if they deteriorate, and decisions requiring more complex aspects of secondary care. And it's useful to have some means by which the patient actually can seek the answers to these, or a template in which they can find a way of getting the answers. So the management of atrial fibrillation, what patients need to know, which are the clinical practice guidelines, forms one of many of these patient guidelines by the ESC. And the idea is to provide information to patients, carers, and relatives about their condition, to inform patients of what to expect in the management of their condition, and to increase the awareness of risk factors, the importance of comorbidities, and help the patient actually self-manage or empower them to manage their own condition, but also to promote a dialogue between the patient and their clinicians at each stage of their care, and to promote joint decision-making. Now, one of the core features of the ESC guidelines is the AF care approach, and you will have had presentations which have highlighted this before. What are the important features here is that it is a patient-centered approach, and that the care is integrated between different aspects of the healthcare delivery. I want to concentrate in particular about the C and E components of this. So comorbidity and risk factor management, which now has a top priority, and which does involve a great deal of patient engagement, and also E with the evaluation and dynamic reassessment when patients represent or may develop, as a result of a chronic condition, new risk factors or new problems, and how we pick those up and how we manage them. So just going through these particular aspects, I'm going to go to, firstly, to comorbidity and risk factor management. Here we have the guidelines for the patient's perspective, which include the treatment of high blood pressure, better control of diabetes, requirements for medication for heart failure, guidance on alcohol intake, exercise, weight loss, and general health. I think it's quite important from a patient's perspective to have some key targets here, rather than just a vague, oh, you'd better lose weight. So where possible, these have been included. So aim for a blood pressure of less than 130/80. And I think we all accept now that perhaps the majority of patients with hypertension will have access to their own home blood pressure monitoring. And that's indeed encouraged in primary care. A target of 10% weight loss. Lower intake of alcohol to what? Well, I've indicated here what 3 or less drinks per week is. That's quite a stringent requirement. And then, of course, the general health advice, which we would tend to give any patients with cardiovascular conditions. I'm going to skip over the anticoagulation side of things because I think that's actually fairly well dealt with and will probably be dealt with elsewhere. And symptoms and rate and rhythm control, which is a combination of primary and secondary, perhaps more secondary care, and go on to evaluation and dynamic reassessment. So AF is a chronic condition. Even if the patient has gone back into sinus rhythm, they will continue to have the risk factors which may promote the subsequent development of atrial fibrillation. And there needs to be a facility for the patient to monitor these risk factors and make any appropriate adjustments to their lifestyle, and also for follow-up and to know when they're going to represent. AF is a major impact on a patient, and I think it's not only should we regard it as a major problem, but it's also a great major opportunity, because it's often the first manifestation of a group of risk factors. And because patients are very worried about their heart, and they're particularly worried about the conditions which can be associated with atrial fibrillation. So if we think of those, dementia and stroke and heart disease are amongst the most worrying of all of the conditions that patients can have, cancer being the fourth of those top leagues. So here we have a group of patients who are relatively highly motivated, and therefore introducing knowledge and education about risk factor control is very successful in this particular time. On the right, we've got some ideas as to how the patient should live with atrial fibrillation, because they are going to need to know what sort of exercise to take, how often to take exercise, advice on diet, cholesterol, alcohol consumption, the need to avoid smoking and recreational drugs, and things that are perhaps not so well represented in the literature, but we know are very important to patients with atrial fibrillation and that can have an impact: stress, anxiety, getting a good night's sleep, and the importance of knowing what medications you're on and why they are prescribed. And this can be achieved through an educational program, which we hope these ESC patient guidelines can provide the basic structure for. How that's actually delivered, of course, depends on what resources you have in your own primary care setup, and whether you have a group of specialist nurses or whether you're going to engage pharmacists. But there are a variety of ways in which education of the patients and getting them to self-manage their conditions can be achieved. So if we think about the various practical issues as to when you have the guidelines and you've got a printed copy of the guidelines, or you're going to give the patient a link to the website, I think the best opportunity is, once the diagnosis is made, giving these before the diagnosis has been confirmed can be somewhat confusing, but it's important that the patient has these to look at. Now, it may not be possible at that stage to go through all of the aspects of what is in the guidelines, but I think what is quite important is to allow the opportunity for a follow-up to answer any questions they may have, or, and very importantly, is that their carers or their relatives also have copies of the guidelines. It's very confusing for patients who travel across different specialties to get different messages from each. And I think if where possible, it's important to disseminate these guidelines as widely as possible to those healthcare professionals who may encounter patients with AF, which is a very large proportion of the secondary and primary care healthcare delivery. In terms of who's actually going to discuss or have a conversation with the patients once the guidelines are raised and questions have been decided by the patient or their relatives, well, again, that is very much for the individual healthcare deliverer to decide. I think it's a very good role for cardiac nurses or community nurses. It doesn't have to be, I don't think, doesn't have to be specialist nurses. You don't need to have nurses that are specialists in AF, because a lot of this is general guidance that will be delivered to a lot of patients with cardiovascular disease. So I would encourage, in fact, all of you to have a look at the guidelines and read through them. The main guidelines that are delivered by the ESC, even though they have been reduced in size, are rather bulky. And in terms of primary care physicians, if you had to read through every guideline, you'd be here until kingdom come. But these are a relatively important summary, which are important both for the patient and I think for those physicians delivering the care. So I'm going to stop there because I gather there will be, I hope, some questions, and we can discuss anything that's arisen during that presentation.
Thank you, Jeremy, for taking us through that, and obviously all of the work that you've been doing, not just on these patient version guidelines, but lots of other international projects and with the, you know, to advance the kind of the patient empowerment angle, I think is really critical. Just while we're waiting for questions, which by the way you can add to either the Q&A or the chat, we'll keep an eye on both. So it feels like in cardiology we're a little bit behind the curve in terms of the patient empowerment side of things. I mean, I kind of liken sometimes what happened in kind of type 1 diabetes, where you have patient in control really of their healthcare. What do you see as the prospects for kind of developing those sorts of things within AF? Because as you mentioned in your talk, it's really about, you know, those key points which actually could end up that patient, if they don't address them, ending up in hospital, could actually be dealt with much earlier, couldn't they, if we kind of empowered the patient to take control?
And I think we recognize that although we may think about curing AF in terms of getting the patient back in sinus rhythm, what we really want to deal with is that spectrum of comorbidities that actually led to atrial fibrillation. And so I think it is a very similar approach to the diabetes, that patients should be aware of what their risk factors are. They may be monitoring their own blood pressure. They should be aware of what their cholesterol is and what to do about it. They should be aware of what represents deterioration in their condition, whether it is an important factors that may require them to seek medical advice, such as syncope or increasing breathlessness, etc. And then, of course, they need to know how much to do. And that, to a certain extent, has to be tailored to each patient and will involve a discussion. So how much exercise you can do depends on whether you're 55 or whether you're 75, whether you've got severe arthritis or whether you haven't. So it has to be tailored, but it is still very feasible.
Thanks. I think Marcus had a question.
Hello, I'm Marcus. I'm a GP in DaRe2THINK, which is down in the southeast. And, you know, a lot of what the things you mentioned, I put in the chat already, should really be covered by your GP surgery. You know, with our chronic disease specialist nurses, we have a GP with specialist interest, not a person with a horse and a cart, doing cardiology, particularly on heart failure. You know, there are a lot of multidisciplinary team meetings where particularly with the homebound people, you have an additional sort of factor of they cannot do necessarily exercise or all these things which would be healthy for them, and weight loss is increasingly difficult. So we should have all of this. Yes. But it also comes in the context that unfortunately our cardiology services are dire, as in totally overwhelmed, and a current urgent chest pain referral, just to put it in context, is 17 weeks wait.
Yeah.
By which time either the person has died or has been admitted, you know, for angina. So that is where we are. But I do also think that a lot of the stuff you mentioned is pretty much what we tell our patients. So it's very much also about what matters to the patient, not what is the matter with the patient. So having that patient-focused approach and say, what's really important to you? What do you really want to do? What do you want to do with your life? And we make sure that we can enable you to do as much as we can. That's really the crux of the question. And then all of the recommendations from the guidelines we shared, which are brilliant, really, falls out from that, really, in my eyes.
Yes, Marcus, that's really encouraging with what you're doing. It sounds as if you've got a really good setup there, and I'm sure it's what a lot of practices aspire to and have. There will be a few that aren't as well resourced, and one has to take into account, well, how are they going to achieve this? That's why I think it's very difficult to be prescriptive. But I think, you know, using pharmacists and using your specialist nurses, having GPs with specialist interest is very important. And I recognize the workload. And I recognize also that you have difficulty in accessing secondary care. I live in the southeast. I'm just outside Bromley. I do recognize that we have to look at every congestion point in the system. There's no point in doing one and not the other. But I think what I'm trying to get across here is that this is achievable. And if we can prevent atrial fibrillation occurring, if we can keep people in sinus rhythm once we've treated them, then the need for ongoing referral to secondary care will be less. And I think Deepak would agree with me that this is one of a major priority here if we're going to lessen the load on secondary services as well. Does that make sense, Mark?
I agree. And I think actually what you talk about also then hopefully lessens the impact on primary services as well, because, you know, just like in that kind of diabetes or heart failure, which I think are a lot better, you know, that idea that this is not a, you know, this is a syndrome, it's a complicated, you know, it's convoluted, as you said, lots of different comorbidities. I think other services have done that much better. And I think we're slowly getting to the point where AF is reconsidered as one of those kind of lifelong conditions where we actually need, you know, the holistic approach across all services, as you mentioned. I think, Naresh, you had a question?
Yeah, I'm Naresh Char, I'm a GP in Stursley in South Birmingham. We've been screening for AF, I think, in various studies for quite a few years, and we until recently had initiation for anticardiac services, including warfarin, which unfortunately has been decommissioned by the ICB because the numbers are actually very, very small now. And people have become de-skilled to some extent. I think one of the things that Mark has mentioned is now a sort of, we have social prescribers and other people working within primary care who actually are really good at engaging with the patient and getting them to look at some of the sort of, if you like, the softer non-medical issues that actually seem to trouble the patients a lot more than sometimes the medical issues. So, you know, their housing, their smoking, the alcohol, depression, anxiety, you know, interpersonal relationship issues. So I think as a sort of PCN, we have a fairly good, well-supported social prescribing service, really good clinical pharmacists who work with us.
Yeah.
And that's actually starting to get the patients more engaged, not just with AF, but just all the chronic conditions. So I think that is probably the model going forward. It's very difficult when you're a single-handed or a small practice, whereas if you're a 10, 12,000 patient practice, you've got paramedics and others who work within your team. And at a PCN level, I think there's an opportunity that probably needs to be developed further to look at some of these chronic multi-comorbidity type patients to actually get a handle on them and get them to self-manage and demedicalize some of their treatment or some of their management.
Yes, and I agree entirely. I would be very interested to know what you feel. I mean, there are increasingly specialist nurses in various areas. You may have specialist heart failure nurses or community heart failure nurses. You may have specialist diabetic nurses as well. We have slightly the same problem, I think, here is that you don't want your patient seeing each of those. If they've got those three conditions, which they may well have, diabetes, they may have heart failure and atrial fibrillation. And how you manage that may be facilitated by making sure that there's a degree of generalism amongst the specialist nurses, so they can handle, if there are heart failure nurses, they can handle issues with AF, and there's a lot of overlap. Or if they're a diabetic nurse, they can handle a lot of issues related to atrial fibrillation. You may have some ideas on that and how you would go about that and what your plan would be.
I think one of the things we've been toying with for a little while is to have a clinic run by a GP plus supported by the specialist nurses or a PA who basically looks at the patient, does all the monitoring that needs to be done anyway, and then have a a sort of 30-minute conversation with a lead clinician who has an interest in saying, okay, you've got these 4 conditions. There's a commonality in terms of these are the key things that you need to do, respective of what the diagnosis is. There may be a little bit more specialism in 1 or 2 areas that you need to understand a little bit more. And there's also this, we did a pilot for a while on group education. That was led with, I think, at one stage with COPD and asthma, and also with diabetes. And I think there's an opportunity to sort of restart something like this to say, okay, all your patients with, say, cardiovascular disease as a group, and that includes AF, these are the key things that you need to be able to follow and understand, and engage the patient to some extent. Get them to lead the actual sessions and have a clinician available to actually talk to somebody one-to-one after the session if they want to. And this is something I think we've been talking about for a little while, and I think it's an opportunity to actually start doing something like this.
I think that's a good model. I know that when I was running the community heart failure service in Oxford, one of the things that was quite important is that the community heart failure nurses or the specialist nurses had somebody that they could link up to. Now that could easily be with a GP with a specialist interest, but it's also possible. I used to run a consult session each week to have that with a cardiologist who has an interest in this in secondary care. One of the problems I think we have is that we don't have many general cardiologists at the moment, and they tend to be subspecialists. And I think sometimes you don't need somebody who's an ablation expert for some of these problems, but you need to have somebody who has a more general view.
Great. Well, thank you so much for the comments and questions. I'm sure we could have another 4 hours of your time, Jeremy, but if we do get any other questions, you can send them in to us and we can forward them on if that's all right with you. So thanks so much for giving us your perspective on this and how important it is. There's a few, whilst Alistair's talking, I'll try to answer a few more of the chat questions, which are more guideline read, or you're happy to actually pitch in as well, Jeremy, on the chat. But I'll hand over to Alistair now to just finish off the webinar today. Thanks.
Great, thank you all, and thank you, Jeremy, for that really interesting presentation. I'm just quickly going to share with you some information about the DaRe2THINK trial, who is the host of this webinar. So I'll just quickly share slides, and I'll keep it as short as I can. So hopefully you can see my slides there. Great. So the DaRe2THINK trial is a National Institute of Health and Social Care Research funded collaboration between the University of Birmingham and Clinical Practice Research Data Link. The project is looking to use routinely collected NHS primary care data to integrate clinical research into usual NHS care, reducing the burden on both NHS staff and patients. The DaRe2THINK trial is an exemplar of this new delivery method and targets a key public health issue of how to prevent cognitive decline and vascular dementia in patients with atrial fibrillation. The trial, through its collaboration with Clinical Practice Research Data Link, is able to screen over 13 million NHS records to identify potentially eligible patients, and now has over 480 GP practices that are already actively screening and recruiting patients to the trial. We are currently seeking new practices using the EMIS healthcare system to take part in the trial, but we've already had a really great patient uptake into DaRe2THINK, with over 1,100 patients now recruited and a 20% uptake of patients that have been invited by their GPs, showing that this is a really key area for us to target for patients with atrial fibrillation. Patients can take part in this study completely remotely, and they're able and hopefully be able to reduce the burden on patients and NHS staff. So, as I said, we're still looking for practices to take part in the study. Unfortunately, at the moment, we're only able to accept EMIS practices. But if you are interested in finding out more, then please scan our QR code on the slides there. If you are a current DaRe2THINK practice and you want to get some support on the trial or remind yourself exactly what you need to do on the trial, then again, there's a QR code there. scan it. You can book a meeting with a member of our team at any point, and we will talk you through exactly what you need to do. So thank you very much. I hope you have a great rest of the day, and thank you again for joining us.